The next section we have here, this is epigastric pain. And in epigastric pain, the simple question is, what's the most likely diagnosis? Well, first of all, what is the epigastric area? The epigastric area is this thing here under the xiphoid process, and here's the pain. Now, one of the hardest things for a medical student to understand at your level is that there's a difference between the word pain and tenderness. Pain means it hurts. Tenderness is different. See, tenderness means that it hurts when you press. So tender is the pancreas. Tender in the epigastric area is the pancreas, and the pancreas is an increase in my amylase, an increase in my lipase, it's an increase in my CT scan, and we have the usual NPO fluids and pain medications. So tenderness is different. So you have epigastric pain right here. Epigastric pain is one of the most common discomforts there is. So what's the most common cause of epigastric pain? Well, I'll tell you what the most common wrong answer is. The most common wrong answer is reflux disease. Reflux disease is associated with pain that goes up and is substernal. Pain that goes up and hits the back of the mouth and makes a sore throat. Pain that goes up and hits the vocal cords and hits the back of the tongue and gives you a bad taste in the back of your mouth. Pain that goes down and hits the cords and makes you hoarse. Pain that goes in the epigastric area and the pain in the acid hits the substernal area, sore throat, bad taste, vocal cords, bad makes you hoarse. Pain and it goes into the lungs and gives you wheezing and a cough. Because 25% of chronic cough is reflux disease. That's reflux disease. Why does it give you a bad taste? Well, you could say it gives you bad taste because it's acid. The other part about epigastric pain, the bad taste, is it's not just that it's acid, it's that what are the taste receptors in the back of the tongue? The taste receptors in the back of the tongue are the 9th and 10th cranial nerves. And the 9th and the 10th cranial nerves convey bitter taste. Oh, you bitter hug of mortality, says Walt Whitman, I draw you near to myself. Tell the physician and the priest to go home. To any who lay dying, thither I speed and twist the knob of the door. If you want me again, look for me under your boot soles. The bitter hug, bitter taste of humanity is in the posterior third of the tongue. And that's because it's the 9th and 10th cranial nerves. What do the vagina and the 7th cranial nerve have in common? The vagina and the 7th cranial nerve, they supply the sensation of taste, but only to the anterior 2/3 of the tongue. A little physiology humor. So the thing is that it hits the cords and hoarseness, wheezing, cough, that's reflux disease. But reflux disease is not the most common cause of epigastric pain. The second most common wrong answer is to say ulcer disease, is to say peptic ulcer disease. But peptic ulcer disease, whether you say duodenal ulcer disease or gastric ulcer disease, is not the most common cause of epigastric pain. It's not. And neither is gastritis. Now, gastritis can also cause epigastric pain, but a gastritis is mostly a cause of pain, less bleeding. It's most commonly a cause of pain, less bleeding. Epigastric pain, no, gastritis is pain, less bleeding. Peptic ulcer disease, a misnomer. Why do we call it peptic ulcer disease? Why you call it peptic ulcer disease? What do you mean gastric ulcer and duodenal ulcer? What's peptic ulcer? If it's gastric ulcer and duodenal ulcer, it's a mistake. It's a mistake the same way Brad, who made Pepsi Cola. Pepsi Cola was named because we used to think that pepsin caused the ulcers. After all, Doesn't pepsin dissolve protein? Isn't the stomach made of protein? Well, protein must be dissolved by pepsin. So it's called peptic ulcer disease because peptic ulcer disease is a misnomer. It's a mistake, baby. We thought it was pepsin. It's not pepsin because remember, at the time that Pepsi Cola was made, he thought he was helping you make a digestive aid because if I acidify the stomach and I make pepsinogen active, I'm helping your digestion. Pepsinogen activating cola. A mistake. Peptic ulcer because it's caused by pepsin from pepsinogen melting down proteins. A mistake, because those guys had never heard of Helicobacter pylori. So you take Helicobacter pylori so much for granted, you think we always knew. You don't understand that almost all the attendings over 40 that you round with, over 50, every attending, every chairman of medicine that you round with was trained to think that acid caused ulcers. Ask them what they were like when they were in medical school. Acid causes ulcers. Use a milk diet. 100% bullshit. Bakwas, sub-bakwas. Khara habibi. Peptic ulcer is a mistake. It's duodenal ulcer and gastric ulcer. And they're caused by Helicobacter nonsteroidals stress. Helicobacter nonsteroidals stress. Gastritis is painless bleeding. Sometimes it's pain. So ultimately, the most common cause of epigastric discomfort is non-ulcer dyspepsia. Now, in the stomach, people don't seem to get this. They don't seem to understand that. The most common cause of pain there is non-ulcer dyspepsia. You mean a functional pain? A non-ulcer dyspepsia? You mean a person who's got a negative scope, a negative barium, and they just have pain in the epigastric area, and that's it? Mm-hmm. Let's refer these to the other things. What's the most common cause of headache? Most common cause of headache. What's the most common cause of headache? It's a tension headache. What's the most common cause of a headache? It's a tension headache. Not temporal arteritis, not a brain tumor, not a subarachnoid, not a subdural. Tension headache. What's the most common cause of headache? Functional headache. So non-ulcer dyspepsia is like a tension headache. What's the most common cause of depression? It's not your dog dying. It's not your mother dying. It's just you're sad. People are sad, man. They're sad. It's a disease. So what's the most common cause of epigastric pain? Non-ulcer dyspepsia. Non-ulcer dyspepsia, you can call it functional dyspepsia. You can call it people who have pain in their epigastric area. Their scope is negative. Their CT is negative. Their Helicobacter pylori is irrelevant. And they just got pain in there. And they, what do you do about it? Well, you know, you give them PPIs. Epigastric pain. You see, now what if the pain in the epigastric area, what if it goes down there into the right lower quadrant? What's down there in the right lower quadrant? This is indispensable knowledge. What about the right lower quadrant? What's down there in the right lower quadrant? What's down there in the right lower quadrant? Well, appendicitis, ectopic pregnancies. Appendicitis, ectopic pregnancies are down there in the right lower quadrant. That's where your appendix is. I had appendicitis. I was misdiagnosed at a major medical center in New York City. Medical student comes by, goes, I was like, She's like, can you sign my book? Yeah, all right, sign your book. Can you get me my CAT scan? No, thanks for signing my book. Bye. No. I couldn't get a CAT scan. I had to call someone from the outside. It's Conrad. Listen, I am in the right lower quadrant. I got appendicitis. I diagnosed myself. Get over here. Don't go to university programs in New York City. So in the right lower quadrant is appendicitis. The right lower quadrant can be ectopic. The left lower quadrant is diverticulosis. The right upper quadrant, what's up there in the right upper quadrant? Not too much. Not too much, but right? Where's my liver these days? Is my liver up there? I think it is. I think my liver's up there. Where's my liver up in the left? I can never remember. So the whole point is you need to know that left lower quadrant is diverticulitis, right lower quadrant could be appendicitis or ectopic pregnancy. Right upper quadrant can be the liver and the gallbladder. And left upper quadrant is not too much, it's the spleen. Left upper quadrant is the spleen, the stomach. What's there? What's there? And if it's in the center, pancreatitis and aortic disease. What's in each of the quadrants? Liver and gallbladder is in the right upper quadrant. Appendicitis and ectopic pregnancies. Ectopic pregnancies need the lower quadrant. I've got epigastric pain. What is it? Non-ulcer dyspepsia is the most likely answer. Non-ulcer dyspepsia? Yep, non-ulcer dyspepsia is 50 to 90%. Non-ulcer dyspepsia is 50 to 90% of the epigastric pain. All the tests are negative, and you treat it with proton pump inhibitors. H2 blockers are bullshit, and sometimes we treat Helicobacter when we don't know what else to do. Treating Helicobacter will make it get better 10% extra time that we give Helicobacter treatment when we don't know what else to do. We have epigastric pain. If there's tenderness, high amylase, high lipase, CT, make it its pancreas. It's pancreatitis, because pancreatitis is tender. Ulcers are not tender. This is one of the biggest misconceptions and mistakes from medical school. Ulcers are not tender. Ulcers are not tender. Only 10% of the time is ulcers tender. Reflux disease. How do I know? Because it'll tell you it's a sore throat, or it's hoarseness, or it's a cough. They don't have to give you all of them for you to know it's reflux disease. They could just tell you it goes under the substernal area. Reflux disease. The best initial therapy, the best initial test is to give a proton pump inhibitor. 95% of patients should get better with a proton pump inhibitor for reflux disease. If you fail, if you're not controlled with a PPI, if you fail, remember 95% of people should get better. What about the 5% of people who are not better? The 5% of people who are not better should get a 24-hour pH monitor. They should get a 24-hour pH monitor to answer this question. Is this really reflux disease? Maybe you don't really have reflux disease. Is this really reflux disease? Maybe you don't really have reflux disease. 95% should get better. Now, what if you have a person who doesn't get better and they really have reflux disease? Hey, 24-hour pH, why'd you fail? Why'd you fail therapy? Why'd you fail therapy? You should get better. Why'd you fail therapy? Confirm it. Confirm it. What does a scope endoscopy, upper endoscopy, what does a scope or upper endoscopy show in reflux disease? If you were in live class, you would be wrong. If you were in live class, you would be wrong, because most medical students think that the scope shows something, and the scope doesn't show anything. If the scope shows something, it's Barrett's esophagus. Barrett's shows something. Barrett's needs to be scoped every 2 to 3 years. Barrett's needs a PPI. If Barrett shows dysplasia, if Barrett shows low-grade dysplasia, if the thing is associated and the Barrett's has progressed to low-grade dysplasia, you should be scoped in 6 months. Because your Barrett's has progressed to low-grade dysplasia. The scope in reflux disease does not show anything. A person comes with epigastric discomfort. That epigastric discomfort goes into the substernal area. There's a bad taste in the mouth. There's hoarseness and cough and a bad taste. Endoscopy shows nothing most of the time in reflux disease. If it shows something, it's Barrett's esophagus. This is metaplasia. That's metaplasia, columnar metaplasia. It's just Barrett's. Scope every 2 or 3 years with a PPI. Oh, it's low-grade dysplasia. Scope in 6 months. Oh, what if it's high-grade, worse dysplasia? What do you do if it's high-grade dysplasia? And the answer is, we used to do surgery to resect the whole distal esophagus, or now we scrape it out, scoop it out, laser it out, radiate it out. High-grade dysplasia, scrape it out. Endomucosal resection. Endomucosal resection. Now, here we go again. Let's take it from the top. What's the #1 cause of epigastric pain? Non-ulcer dyspepsia. That's 50 to 90%. And the age group most of you are in, do you know that 25 to 30% of medical students and residents are using PPIs and H2 blockers on a regular basis? Now, on your test, H2 blockers are never the right answer because they're never better for anything. They're never better for anything. PPIs are always better on your test. H2 blockers people use because they're less expensive. But in the test, they go for efficacy #1. Efficacy #1. So you have non-ulcer dyspepsia, and you should have all negative tests and a proton pump inhibitor, anti-secretory therapy. It doesn't get better and you're still bothered. If your Helicobacter is positive, we can treat Helicobacter pylori and it will improve things an extra 10%. Crappy. There's tenderness, in the epigastric area. That's pancreatitis. High amylase, high lipase, CT scan shows pancreatitis, NPL fluids, pain medications, pancreatitis is tender. Oh, it goes up into your chest, into your substernal region. Second most common cause of epigastric pain, reflux disease. Sore throat as the acid hits the back of the throat. Bad taste because it hits the posterior third of the tongue. Cords and the hoarseness and the cough and the asthma and the wheezing. PPIs. 95% should get better with PPIs. The 5% that don't get better, hey, you're not better? This should get everybody better. What do you mean you're not better? 95% chance if you're not better, it's not just reflux. You better confirm it's reflux with 24-hour pH monitoring. Failing therapy, confirm. Failed therapy, confirm. And failed therapy, confirm. Oh, it's Barrett's esophagus, scope every couple of years. It's low-grade dysplasia, scope every 6 months. It's high-grade dysplasia, scrape it out, scrape it out. Distal esophagectomy, endomucosal resection, scrape it out. Scrape it out before it becomes esophageal cancer. So what is caused by Helicobacter pylori? Despite the fact that this is a very common disorder, Helicobacter pylori is greatly mistreated and misunderstood by medical students because it's hard to understand that Helicobacter pylori is carried by the majority of the population. So the reason why this is hard to understand for people is that we don't treat Helicobacter pylori unless there's symptoms and abnormalities that go with it. That's very hard. It's so hard, I'm going to say it 4 more times. We don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. We don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. Again, we don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. In other words, Helicobacter pylori is not an illness. Half the population, particularly the bad Hindus, the people eating sausages and unrefrigerated meats, are all colonized with Helicobacter pylori. Helicobacter pylori is treated for these things: duodenal ulcer, gastric ulcer, gastritis. Very rarely are they treated in non-ulcer dyspepsia. So the diagnosis of Helicobacter pylori is very, very difficult because I have 2 answers for you. Serology is something that clinical doctors never do, but for your test, the answer to which of the following is very sensitive It's very sensitive. A negative Helicobacter pylori serology means you don't have Helicobacter pylori. And if it's positive, Helicobacter pylori can't tell old versus new disease. So this is one of the exceptions where you're going to want me to say, do this test first, then this test, then this test. Do you want me to, I know what you want me to say. You want me to say, do serology, then do breath testing, then do endoscopy. And I can't do that. If you scope someone and you biopsy them, and you say, I have a positive biopsy, the duodenal ulcer, the gastric ulcer, the gastritis. For Helicobacter pylori, it's real. You don't need serology. You don't need a breath test. You don't need a Helicobacter stool antigen. Helicobacter serology is almost never done. If it's negative, you don't have Helicobacter. Breath testing and stool antigen can tell you old versus new disease. Helicobacter pylori breath testing and stool antigen can tell you old versus new disease. Serology cannot tell you old versus new. Breath testing and breath testing and stool antigen can tell you old disease versus current infection. But serology cannot. Now you know why serology is really very difficult. It's not very accurate. Accuracy is a combination of sensitivity and specificity. You won't hear the fish talking about the word gold standard because it's like some vague ass bullshit term. Gold standard. I don't use that word. I say accurate. Serology is not accurate. It's very sensitive, but it can't tell old versus new disease. And we have a population where half the population has Helicobacter pylori. It's an unrefrigerated meats. All you Italians, all you sopressata eaters, all you Turks and Greeks eating lucanico, you're all serology positive. Is it old? Is it new? Forget it. Breath testing and Helicobacter stool antigen. You can see the Helicobacter pylori antigen in the stool. You can see the Helicobacter pylori antigen in your stool. You're basically testing your stool for Helicobacter pylori stool. It's kind of like guaiacking a Helicobacter in your stool. And it can tell old versus new. But if you're going to scope somebody, you don't need to do either of these tests. If you're going to scope someone, you have the answer. That's the most accurate test, endoscopy. So you might say to me, okay, Fish, I have a person who's got epigastric pain. There's no tenderness. And so since there's no tenderness, it's not going to be ulcers. It's not going to be pancreatitis. And gastric cancer is really unusual. And I have epigastric pain, and you just told me that up to 90% of it is just functional dyspepsia, non-ulcer dyspepsia, and I have epigastric pain. So where does that leave me? Am I supposed to scope him and not scope him? Give me an answer. Well, let me explain. Don't explain anything to me. Just give me an answer, because I don't understand shit, okay? I just want to give the answer. I understand this. I understand this. And I'm going to tell you why that sort of thinking. I was in the hospital today with medical students, and I was thinking how great attention deficit disorder is. I personally love attention deficit disorder. I love attention deficit disorder because it means you get the answer fast, you got to figure it out fast, because we lose our attention the next minute. So Conrad says to you, epigastric pain, 90% of the time is not dangerous. Well, what about the 10% of the time? It might be dangerous. Okay, I have two answers for you. If you have a person who has weight loss, you need to be scoped right away. Functional dyspepsia does not make you lose weight, and frankly, most people are gaining weight. Most affluent Americans, Europeans, Japanese, the people who have access to unrelenting food, we're getting fatter all the time. So if you're over 40 or 50, and you're losing weight, unintentional weight loss means cancer above the age of 40, 50. Above the age of 50, definitely. You're losing weight, you better get scoped. You have guaiac, you got blood in your stool, you better get scoped. Bullshit. Forget about this Helicobacter stuff. Forget about anything else I told you. Forget about, is it tender or not tender? Trial of PPIs. Forget all that shit. Just go in there and scope them. You shouldn't be having anemia and guaiac positive stool. These people are sick. You're going to miss cancer. Get the hell in there and scope those people. Now, you have dysphagia. You shouldn't be having dysphagia. You can't let people have epigastric pain and dysphagia know. Okay, you better get in there and scope those people because they got a cancer. See, what I'm saying to you first is this. Epigastric pain, what is the most likely diagnosis? Non-ulcer dyspepsia. But non-ulcer dyspepsia is more often in younger people, under 40, 50. That's medically young. 30 is like, teenage. It's like puberty. Medical puberty is about 38. But if you have weight loss, anemia, guaiac positive stool, all of these people should be scoped later. We all call these people, this is called alarm symptoms. And alarm symptoms mean scope now. So that's the answer to the question. Now the good news is because you're preparing for a standardized test, if they want you to know the answer, they have to tell you something. So if they want you to answer scope, they have to tell you. So they tell you weight loss and anemia, guaiac positive stool, dysphagia. Holy crap, man, scope. You're excluding cancer. Next, you have epigastric pain and you're above the ages of 45 or 55. I wish I can give you one answer, but one society says 45, another society says 55. I'm intercoursed, what can I do? So people who are medically older, so to speak, and those people should generally be scoped. So they're not going to play a game with you. They're going to tell you the person's 60. They're not going to say they're 51, but they're very youthful. They're going to say, dude's 70, get in there and scope that guy. Why? Because you got to exclude cancer in older people. Okay, medically young. You're 35, 45, medically young. You're under the age of 45 or so. You try PPIs, anti-secretory therapy, and if that fails, then you scope them. So yes, it breaks up into a couple categories. The first one is easy. You got alarm symptoms. You got anemia. You got weight loss. Your dysphagia. You got blood in the stool. Scope them. There's no screening when you got blood in your stool. Scope them. You're older and you got epigastric pain. Scope them. But so many of you who are watching this, and you're 22, 24, 26, because most of the people who are watching this are the under 30, 40 generally healthy crowd. And you, my generally healthy, under 30, 40 generally healthy crowd, if you fail anti-secretory therapy, then you should be scoped. But you might say to me, look, fishy. I can do serology, and if the serology is positive, I can do the breath test. The breath test is positive, or the Helicobacter stool antigen is positive, and if the breath serology is positive and the breath test or stool antigen is positive, I can go ahead and give you a proton pump inhibitor and 2 antibiotics like clarithromycin and amoxicillin, clarithromycin and metronidazole, clarithromycin, amoxicillin, metronidazole, tetracycline, bismuth. Why do I need to scope you if I can go ahead and treat Helicobacter? Because that PPI is going to get rid of ulcers and gastritis. It's going to get rid of ulcers and gastritis. It's going to get rid of ulcers and gastritis with 95, 96, 97% sensitivity, accuracy, efficacy. Why do I need to scope anybody? Do the serology. If the serology is positive, do the breath test and the stool antigen. And if the breath test and the stool antigen is positive, give them a proton pump inhibitor and 2 antibiotics, clarithromycin and amoxicillin, metronidazole, tetracycline. Why scope anybody? The answer is very straightforward. Cancer. Ultimately, you can't tell which person is one of the 4% that will have cancer. 4% of gastric ulcers have cancer. And 4% to you might seem very small. It seems small unless it's your cancer. Because if it happens to you, and it's your cancer that's missed, it's 100%. Because you're the only one of you that you have. So 4% is small if it's not yours. You're scoping people to make sure people don't have gastric cancer. Duodenal ulcers have no cancer. How do you tell if somebody's got a duodenal ulcer or gastric ulcer without endoscopy? How do you tell? Oh, better with food for duodenal, worse with food. It's an approximation. It's an approximation. It's an approximation. It's kind of bullshit, old stuff. Better with food, worse with food. Not good enough. It's like lucid intervals with epidural and subdural hematoma. Both epidurals and subdurals can give you lucid intervals. I get hit in the head, I pass out, I wake up, I pass out. In between is a lucid interval. Not good enough. Menstrual histories for ectopic. Not good enough. Not good enough. We need much more precision. And medicine is more precise than it used to be. If you'll get your shit together, it is anyway. Not if you keep going off of old answers from old books or stupid faculty that are teaching you from the ancient land. It's easy for faculty to teach you things like, oh, you'll know it's duodenal ulcer if it's better with food, and you'll know it's gastric ulcer if it's worse with food, because that saves the problem of having to be accurate. You can't tell for sure. Your job is to make sure you don't miss a gastric ulcer. And if you've had a gastric ulcer, and you ever waited around for the result of biopsy, you will see that that 4% for gastric ulcer cancer, the person who's waiting for the result of biopsy, that person does not think it's a small risk. I got a 1 out of 20 chance of cancer. I'm going to die. I'm going to have my stomach resected. So that's why you're scoping. Gastritis does not cause cancer. Duodenal ulcer does not cause cancer. You're scoping to look for cancer. You could diagnose Helicobacter pylori with serology breath testing or stool antigen. But you can treat with proton pump inhibitor and 2 antibiotics. But you can't exclude cancer. Treating for non-ulcer dyspepsia, that's most of the epigastric pain. A small number of them will get better with treating Helicobacter pylori, maybe an extra 10% if somebody has been treated with PPIs and still not better. This section is called epigastric discomfort. The most common cause of epigastric discomfort is non-ulcer dyspepsia. The one most likely to be tender is pancreatitis. Ulcers are rarely tender, 10 or 20%. When do I have to go in and scope right away? Alarm syndromes, weight loss, anemia, dysphagia, scope right away. When do I have to go in and scope right away? When they're older. They're not going to play a game with you and say 51. They're going to tell you alarm symptoms or failed PPIs and anti-secretory therapy. Last question. A person comes in with reflux, clear epigastric pain, substernal, sore throat, hoarseness, and that person with reflux has a positive breath test for Helicobacter pylori, a positive stool antigen for Helicobacter pylori, a positive serology, and they have reflux for Helicobacter pylori. What do you do about the person with reflux and Helicobacter pylori? What do you do about the person with reflux and Helicobacter pylori? What do you do about the person with reflux and Helicobacter pylori? You must, of course, not treat. Not treat. No, because Helicobacter pylori doesn't cause reflux disease. Helicobacter pylori doesn't make your sphincter loose down there. Don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. Don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. Again, don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease.